Dr. Bodian is an assistant professor in the Department of Neurology at Massachusetts General Hospital, affiliated, as you know, with Harvard Medical School. She's also the associate director of the Laboratory for Neuroimaging of Coma and Consciousness and a research scientist in the Department of Physical Medicine and Rehabilitation at Spaulding Rehabilitation Hospital, a traumatic brain injury federally designated model system. Many of you have worked in hand with Dr. Bodian, both in terms of your clinical endeavors, but also your research interests. I'm thrilled to invite and have her accept doing this webinar today. Just a couple of housekeeping things. If you could put your questions into the chat room, I believe Dr. Bodian will finish approximately 10 minutes early in time for some Q&A, and then we will have a hard stop at the top of the hour. With no further ado, welcome Dr. Bodian.
Thank you very much, Dr. Weintraub, for that wonderful introduction, and to Jennifer for arranging this webinar. Today's talk, we're going to interweave recent advances and limitations of TBI research with strategies that will apply the principles of precision medicine to severe TBI diagnosis, prognosis, and treatment. And like Dr. Weintraub said, I'll be happy to take questions along the way. I see some familiar names on the webinar today, so I hope you guys will throw some challenging questions and discussion topics our way. This is my funding support, no conflicts of interest. So in the past 5 to 10 years, our understanding of recovery from severe TBI has grown substantially. And I'll give you just a couple of examples of that. So this is a 2021 TRACK TBI study, which is a multi-center, 18-center actually, study across the US that enrolls patients acutely within 24 hours of a traumatic brain injury and follows them out to 12 months and now even further. And this is a figure showing outcomes at 2 weeks, 3 months, 6 months, and 12 months for the severe cohort in TRACK TBI. Severe as defined by the Glasgow Coma Scale, or the GCS, total score of less than or equal to 8. And the outcome measure here is the GOSI, or the Glasgow Outcome Scale Extended, which you can see is an ordinal scale here with categories, the definition of the categories up top, and a dichotomization of the GOSI, where a GOSI score of 4 or greater is equivalent to a favorable outcome, as you can see here. So what we can see from this slide is that over time, between 2 weeks and 12 months, we have a substantial increase in the proportion of patients with severe TBI who achieve what is categorized here as a favorable outcome, or a GOSI score of 4 or greater, indicating at least partial independence. And we see that the proportion of patients in the lower severe disability category, or in the vegetative state, the light blue and the yellow, getting smaller over time. And this is one of the more recent studies that illustrates to us that even patients with severe TBI with catastrophic injuries can get better over time, and that the proportion of patients with very severe disabilities, or the vegetative state, is actually much smaller than we would have previously thought. Published in the same year, but leveraging data from the traumatic brain injury model systems, which maintains a carefully curated database of outcome data representing 16 acute inpatient rehabilitation hospitals, Dr. Bob Kowalski and his colleagues showed that if you look at emergency department admissions and you look at the proportion of patients who are not following commands, at least in this data set, which is over half, that proportion of patients who are not following commands drops down to about 10% by the time patients get to rehab. And by the time they leave rehab, that proportion is just 2%. Now, if we look at that 10% of patients who are admitted to inpatient rehab not following commands, we can see here that those patients tend to recover at about the same rate as the patients who enter rehab following commands. So patients, and this is how they categorize the source of consciousness in the model systems, by this command following item. So patients who enter rehab without command following, so we could say those are patients with a disorder of consciousness, this orange line, the slope or the trajectory of their recovery is actually even a little bit better than the patients who enter with command following, so they're categorized as not having a disorder of consciousness. And if you extrapolate in your mind this orange line out beyond rehab discharge, you'll see that patients are very likely to achieve a status of independence on the functional independence measure. So just another piece of evidence that indicates to us that the probability of recovering even after a very severe injury is and can be very high. Nevertheless, we still cannot predict who is going to recover, exactly to what degree, and when that's going to happen. And we are still operating in an environment where basically all acute TBI interventional trials in the last 2 decades have been negative. And the question is why? Despite huge efforts and money, global initiatives, we still know relatively little about recovery from TBI. We don't have basic epidemiological figures on how many people with TBI are in a coma initially, how many will end up with a prolonged disorder of consciousness, unable to express themselves or communicate effectively. Like many other neurologic diseases for which we have unanswered questions, TBI is, of course, very difficult to study because we know a lot less about the brain than other organ systems. But TBI is also unique in that no 2 injuries are alike, and no 2 individuals bring to the injury the same combination of factors that can affect recovery. So today we're going to use the existing literature to frame and to try to understand some of the limitations that have prevented us from answering some of the fundamental questions about TBI that we would like to answer in the future. This is a list of 10 common limitations in the literature on moderate to severe TBI. Now, I compiled this list by looking through the literature and the limitation sections, and many of you will probably recognize these limitations. We've read them and written them ourselves. But just to make sure that I didn't miss any, I consulted my very good new friend, ChatGPT. And if you put into ChatGPT, what are the 10 most common limitations of moderate to severe TBI studies, you're going to get a list that looks very similar to this. So this is vetted by AI. We won't have time to dive very deeply into each of these 10 items, but I've highlighted the ones that I'm going to focus on, although I will try to touch, if time allows, on all of the other ones as well. Let's start with perhaps the biggest limitation, the one that we'll spend the most time on, which is that our current methods for characterizing and classifying traumatic brain injury are alarmingly crude. We typically break out acute brain injury into traumatic brain injury and non-traumatic brain injury. I'll talk mostly about TBI today, but certainly many of these principles apply for non-TBI as well. But beyond that, when we think about traumatic brain injury, our ways of classifying the severity is limited to 3 categories: mild, moderate, and severe, based again on the Glasgow Coma Scale, which is a behavioral scale we're going to talk more about shortly. Think about traumatic brain injury. Think about everything we know about how every brain injury is different, how people recover differently, how people bring many different things to the table. And just think about how really alarming it is that at the end of the day, no matter what injury somebody comes in with a TBI, we slap it with a label of mild, moderate, and severe. So that's certainly not ideal, especially in an environment where we know that there are subtle but very important differences, especially in that severe TBI category, between different stages of recovery. We know that behavioral diagnosis is much more nuanced. And over the years, we went from having 3 diagnostic categories of consciousness, namely coma, vegetative state, and fully recovered, to now having 6. We filled in these gaps with the minimally conscious state minus, so the recovery of awareness, the minimally conscious state plus, adding on to the recovery of awareness specific cognitive processes, including language function, emergence from the minimally conscious state, which is also called the post-traumatic confusional state, where things like communication come back online, but there's still profound fluctuation in symptoms, disorientation, cognitive impairment, and many other clinical symptoms. And then finally, orientation. And we know that these different categories are incredibly important for not just diagnosis, but for prognosis. Nevertheless, we are still stuck, at least in acute TBI, with the Glasgow Coma Scale. And let's spend a couple of minutes talking about why that is. I don't know why there's an orange line here, but hopefully it'll go away. So the Glasgow Coma Scale has been around for nearly, coming up on 30 years, more than 30 years actually. And it's used to classify patients in the acute recovery stage. You could say that this is the original behavioral assessment of consciousness. It was rapidly adopted by emergency rooms and ICUs worldwide because it has many positive qualities. It is quick, easy, and it's been validated from multiple different perspectives, including prognostically. So it remains the gold standard. The GCS is composed of 3 subscale scores, as you can see here on the left, each one broken out into multiple items with the scoring here on the right. And the total score combined is primarily what's used to make important decisions, such as whether or not someone's going to have neurosurgical intervention, or even whether or not somebody is likely to continue to recover, which of course affects our ability to to establish prognosis, and affects families' decisions to withdraw life-sustaining therapy, all based on this crude scale. So we took the GCS and we tried to map it onto the DOC diagnostic criteria that I showed you in the prior slide. So we took the highest item from the GCS, which is the verbal score of 5, which is associated with orientation. We mapped it onto the post-traumatic confusional state, recovered from the post-traumatic confusional state diagnosis. We took the next score down, which is confusion. We mapped that onto the PTCS diagnostic category. We then looked at the verbal and the motor score, mapped that onto MCS plus, language function, and so forth. The mapping is not perfect because the GCS does not assess all of the behaviors that we associate with the minimally conscious state, but it was the best that we had because when you look again acutely, we only have the GCS. Once we did that mapping, we took a look back into our track TBI data, which I just spoke about in the prior slide. This is that big 18-center study with thousands of patients. And within each GCS total score, which you can see here on the x-axis, we looked at the percentage of GCS scores that meets each of these diagnostic criteria on the right. And I want to point out to you 2 specific scores. The first is a score of GCS 8. GCS score of 8 and below is what is classically used to define, quote unquote, a severe TBI, and it is very commonly used to define coma. However, if you look at the distribution of behaviors within a GCS total score of 8, you see that the overwhelming majority of patients are actually conscious, MCS minus. Some of them are even MCS plus, and a small proportion of the vegetative state. You actually mathematically can't get a score or a behavioral profile consistent with coma if you have a Glasgow Coma Scale total score of 8. Nevertheless, this is what is used in the literature primarily for severe TBI. And it's used to enroll patients in clinical trials aimed at looking at severe TBI and so forth. Right next door to the GCS total score of 8 is a GCS total score of 9, which is considered moderate TBI, a very different severity category. Nevertheless, the distribution of behaviors common to a GCS score of 9 is almost the same as a GCS score of 8. So I've hopefully convinced you at this point that the GCS is not necessarily what we should be using acutely. But do we have something better? And the answer is yes. Well, sort of. The Coma Recovery Scale Revised, which many of you are probably familiar with, was developed by Dr. Joe Giacino, a colleague and mentor of mine. And this tool systematically and comprehensively measures consciousness using a behavioral assessment that can be done at the bedside. It's now memorialized in clinical practice guidelines from the American Academy of Neurology, American Congress of Rehab Medicine, and so forth. And it's recognized as a tool that should be used in DOC rehabilitation clinical programs for serial assessment of recovery of consciousness. Furthermore, it's recommended by the National Institute of Neurologic Disease and Stroke as a common data element for use in research studies. So what's the problem with the CRSR? Well, it takes 25, 30, sometimes even 45 minutes to administer, which is definitely not something that can be done early on in the period of acute disorder of consciousness in the ICU, when patients are medically unstable and we only have a couple of minutes during which to try to assess their behavior. One of the big proponents of people who use the GCS is that it's quick to administer. So we decided to develop an ICU-validated fast version of the CRSR called the Coma Recovery Scale Revised for Accelerated Standardized Testing, or the CRSR FAST. We took the 23 items of the full-length CRSR, reduced them down to just 5 items based on literature and a panel of clinical users, and came up with a very short scale validated in the ICU. So just to give you a sense of what that scale does, the primary purpose of the CRSR FAST is to really just differentiate patients who are conscious from patients who are not, because that is ultimately the decision factor in many cases about whether or not somebody is going to have prolonged life-sustaining therapy or withdrawal of life-sustaining therapy, whether or not somebody is going to get access to inpatient rehabilitation or not, And so we wanted to make sure that we maximally identified and detected consciousness in patients who were conscious in the ICU. The other thing that the CRSR FAST does that the GCS doesn't is that it very carefully and precisely maps out potential confounding factors that could mask consciousness, so that an exam that is confounded by sedation, infection, intubation, or underarousal is not taken to represent the maximal level of function of a patient. So like I mentioned, we validated this in the ICU. We ended up getting substantial validity and reliability, and the CRSR FAST takes just about 6 minutes to administer as opposed to 20 plus minutes for the full-length CRSR. And if you'd like more information on the scale, you can get it here with these fancy modern QR codes. You can get the paper at Annals of Neurology, and the measure can be downloaded for free on the Spaulding Rehab website. All right. We all know that behavior has a lot of problems with it in terms of assessment of consciousness. Many, many things can affect and confound behavior. So what are our other options for assessment that can help us understand the severity of a brain injury that can complement our behavioral assessment? So imaging is another one, and specifically functional neuroimaging. I won't get into too many details here, but many patients, in fact, 15 to 20% or more of patients who appear to be unconscious behaviorally can actually modulate their brain activity in response to a command. So for example, if you put a patient who has a diagnosis of a vegetative state, they show no evidence of awareness at the bedside, they do not follow commands, they do not speak, you put them in a scanner, a regular MRI scanner programmed to be able to acquire functional data, and you ask them to imagine themselves playing tennis or squeezing their right hand or moving around the rooms of their house. In many, again, 15 to 25% of patients, you can actually see brain activation, which is this orange blob here, within an expected region of activation based on healthy control studies, and that's represented here in green. And in those patients where you see brain activation that matches the pattern of brain activation to the same task in a healthy control, you say that they have a diagnosis of cognitive motor dissociation, a term coined by Dr. Nico Schiff in 2015. This is also known as covert consciousness or covert command following, or CMD for short. And CMD has been demonstrated now both in acute patients and in patients with chronic disorders of consciousness. And most recently, CMD has been shown to be associated with a better prognostic outcome in patients who have it acutely. But it's actually very hard to do this task in the scanner. And about a quarter of healthy control subjects don't show us the activation that we would anticipate them to have. So ideally, what we want to have to really get down to being able to carefully characterize patients with TBI based on their brain function and their severity is something that bypasses any need for a volitional response. And we have that in something called TMS, or transcranial magnetic stimulation, paired with EEG, or electroencephalography. The idea here is that you can ping the brain, and you're actually pinging cortical thalamic circuits, and you can measure the response to that pinging using a measure called PCI, or the Perturbation Complexity Index, which is a very fancy term, but it basically tells you how complex is the brain's response to a perturbation. It requires no attention, no cognitive response for the patient, but has a very high sensitivity for detecting consciousness in patients who are behaviorally conscious. And it's been shown to have diagnostic validity as well as prognostic validity. So an example of how we can really get at brain function without having to use behavioral assessment. And then we also have much more definitive data now on acute blood biomarkers of injury. So for example, high levels of GFAP, or gliofibrillary acidic protein, which is found in the cytoskeleton of proteins, is highly associated not just with mortality, but also with poor outcome in patients with severe traumatic brain injury. And this is another study coming out of Track TBI just in the last year or so. So what you're seeing is that this, limitation number one is that TBI is heterogeneous. But now we have not just GCS, crude behavioral marker of TBI severity. Now we have the CRSR FAST, which will give us more comprehensive data on behavior. We have imaging, and now we have blood biomarkers. And we can start piecing all of this together to help us classify patients on much more meaningful biomarkers of brain severity than just behavior alone. Let's move on to the second limitation. inadequate sample sizes. Again, every study just about will have this in its limitation section. But what does that actually mean? So think about a TBI research study in which you want to characterize outcome. Think about the sample that you would like to get. The larger the sample, the more statistical questions you can answer about that sample. But what happens in practice? You'd like to be able to study everybody with TBI, but what can you actually do in a research study? So this top row here is representing all patients who have a TBI, let's say in your catchment area. This is the number of patients or the proportion of patients who actually end up at your research institution where you can potentially enroll them in a research study. Now we have the number of patients who are actually eligible for your research study. That number is much smaller. Here are the number of patients who actually sign up for your research study and have complete data. And now we're down to the number of patients who are actually followed on your research study. Now take a look at this small sample in your research study compared to the sample you would have liked to have so that you could run all of your statistical tests. These two red dots represent our two included participants down here in the red circle, and the likelihood with which these two people are similar enough to themselves, to each other, and have minimal variance is very small. In other words, when you take two people from a very large sample, they're likely to be very different. You're unable to run any statistical tests on them, and the conclusions that you can make become much, much more narrow. And so this is why, when you have 10, 15, 20 people in a sample, you really can't make very strong statistical conclusions, not because there are no differences or you don't have something meaningful in your data, but because you don't have the statistical power to show it. So what can we do? Of course, we can look at registry or databases where we can have thousands of people, but those are limited, and we'll talk about that in a minute as well. If you're trying to do prospective work in the ICU, perhaps if you're enrolling consecutively every single patient who comes into the ICU, you might get 100 or so patients. But most likely in the world that we work in, where you're not just trying to get lots of ICU acute patients, but you're also trying to follow them long-term, you end up with sample sizes in the tens, 10, 20, sometimes 50 people, and that's if you can follow them long-term. So what's the solution? One solution is putting together a consortia with similar research interests and questions and bringing data in from all around the world into a central database. This is what we've done with the James McDonald Coma Consciousness Consortium to address the question of CMD, cognitive motor dissociation. Prior to this consortium, the studies that we had looking at fMRI or EEG as a diagnostic biomarker for brain injury, those studies had 10 people, 20 people, sometimes 30, and the most recent studies had about 100. But if you wanted to divide those into subsamples of TBI and non-TBI and by chronicity, the sample sizes got very small. With this McDonald Consortium, we have 350 patients in our database collected over 6 sites. And now we have numbers that we can much more closely approximate what might actually be happening outside of that larger sample size. And similarly, Track TBI and the TBI model systems affords us the opportunity to get larger sample sizes as well. And so I think to the extent that we can start thinking about how do we get more people in so that our studies are much more statistically powered to find significant results is a direction that the field needs to go in. And I think the sample sizes of 10 and 12 and 15, are just not viable if we really want to make a shift and we want to start doing precision medicine and individualized medicine. The sample size issue is very closely related to the issue of generalizability, which we also have in our TBI trials. So back to our schematic here are the patients who you'd like to be able to enroll because you'd like to be able to make a study about all patients with TBI. So your conclusion can apply to everybody. The reality is that in just about every single TBI trial that I can think of, whether it's observational or randomized controlled trial, you have a selection bias on a number of different levels. First, out of these patients who have TBI, whose outcome you would like to study, a certain proportion of them are going to die. So you're never going to be able to include them in your study and understand what could have happened to them under different circumstances. And you're not going to study, most likely, the patients with the absolute most severe injuries because they're not going to make it into your research center where you're doing your study. So we go from a large sample size again to a small one, and now this smaller sample size no longer represents the entire pool of TBI patients who you'd like to study. Again, you have the issue of not everybody enrolling in your study, proportion of those patients dying, not everybody making it into your full data set, and not everybody being followed. So again, you have this is now a similar issue where your sample size gets smaller, but now you have to ask yourself whether or not these two people right down here are representative of the full sample size, or are they just representative of your research institution? Are they just representative of an academic center? And you also have to start thinking about who is actually enrolling in your research. If you're familiar with some of the recent studies on healthcare access, and parallel to that, the look at the case mix of patients who are enrolling prospectively into our research studies, we are not getting a representative sample. Our patients tend to be predominantly not from minority groups. They tend to be educated. They're people who want to be in research and want to be followed long-term, and they're people who are easy to follow long-term. So at the end of the day, we have in our sample size a bias. We have only people who are survivors, only those who are admitted to specialized academic centers, only those who are consented and followed. And that's unlikely to be representative of the entire pool of patients who you would like to study. And it makes it very hard to say our research study applies to the broader patient population. Let me give you a couple of examples going back to the first two studies that we talked about. So TBI model system studies are amazing because they follow patients for their entire lifetime, but they only include patients who are admitted to acute inpatient rehabilitation, one of 16 centers in the United States. So most patients with severe traumatic brain injury, the overwhelming majority of patients with disorders of consciousness, never get admitted to inpatient rehabilitation. So our results are always going to be limited to only being generalizable to the patients who get access to inpatient rehab. And we have very few studies that look at long-term outcome in the patients who don't go into inpatient rehab. So that is a selection bias just for the patients who have insurance, who have access, proximity, and who get a referral into inpatient rehab because they are either can participate in rehab or are assumed to be on an upward trajectory of recovery. Selection bias also in our TRACK TBI studies because a proportion of our patients die, not just due to the TBI itself, but due to withdrawal of life-sustaining therapy. And we can't know how those patients would have recovered because, of course, they pass away. They pass away because the clinical team talks to the family and gives most often a negative or a pessimistic neurologic prognosis. The family decides to withdraw life-sustaining therapy, and we don't know how those patients would have done. So what can we do about something like that? How do we move this field beyond those types of selection biases? So one way that we've been trying to address this is by modeling what would have happened to patients who die after withdrawal of life-sustaining therapy. And I won't go into this study in detail, except to tell you that if we look at the demographic and patient characteristics of the patients who died after withdrawal of life-sustaining therapy, and we find a matched sample in the patients who didn't have withdrawal of life-sustaining therapy, and we look at the outcomes of that matched sample, we can approximate what would have happened to the patients who did have withdrawal of life-sustaining therapy, removing that selection bias, that survivorship selection bias from our outcome data. What we see, these are just some preliminary findings, so this isn't published yet, but what we see that many patients who have withdrawal life-sustaining therapy, had they not had that course of action, would have died anyway. However, a large proportion, in fact, more than 50% of the survivors would have achieved what in prior studies has been labeled a favorable outcome. They would have achieved by 6 months or 12 months an independence in the home, and a small proportion of patients could have even recovered to the maximum GOSI score of 8, which is returned to pre-injury baseline. So we can use these data to try to impute outcomes for patients who died from withdrawal of life-sustaining therapy to remove that sort of selection bias from only studying patients who survived because life-sustaining therapy for them was prolonged. What's another thing that we can do? So the Neurocritical Care Society Curing Coma campaign supported a small pilot study, which is a mouthful. It's called COMPOSE, the Curing Coma Campaign, Acute Coma Pragmatic Prospective Observational Study. It is PI'd by Dr. Chetan Rao over at Baylor. And the idea of this study is that we want to go global. We want to go with consecutive enrollments, and we want to get as many people as possible into a small prospective observational study. So this study is designed to enroll patients, like I said, all over the world. So now we're not dealing with selection bias, at least in terms of what we have in the United States, although these are patients who are brought to academic centers that are part of the study. So these are patients enrolled at academic centers and sometimes at small acute hospitals. And they are followed out to at least to discharge from the acute care hospital, sometimes out to 3 months, on a number of pragmatic measures that you can, for the most part, get from the medical record. But the idea here is that this is going to be a much more representative sample, because these are not only patients who get inpatient rehab, not only patients who go to a large research institution, and they're going to be patients from all over the world. So this is an ongoing study that hopefully we will be starting to enroll for in the next week or so. Okay, let's talk about our next limitation, which is that we, in many studies, have minimal high resolution data on the first few days to weeks post-injury. And this limitation actually goes hand in hand with one we're going to talk about a little bit later about outcome. So on the one hand, if you look at data from something like the TBI model systems, where we have great data on outcome, we know almost nothing about patients in their first few weeks of recovery. Think about your local medical record and everything you collect, or everything the acute clinicians would collect. Behavioral assessment every day, medication administration by the hour, continuous monitoring of EEG, continuous monitoring of intracranial pressure, daily lab values, daily interventions. Most of this information doesn't end up in our modeling of prognosis or in our projections of who might recover or who might be a candidate for treatment. Out of all of this information, if you look at the overwhelming majority of studies, even from something like Track TBI, where we do have pretty good acute data, all of this gets funneled down into our table 1 in our research study, which usually includes basic information about the GCS, perhaps a Marshall CT score that takes one CT into account and tries to calculate an overarching score of severity, perhaps information about some contusions that are abstracted from a report, maybe something on pupil reactivity, very, very few metrics. So if we really want to understand TBI heterogeneity and how patients with TBI recover and how they should be classified based on their severity, we really need to be taking into account all of this information, which is now in many cases starting to be done with electronic medical records and bridging between electronic medical records and research medical records. And here, this is something where machine learning is going to come into play, because there's an overwhelming amount of data that has to be brought down into a manageable amount of data that has to be brought down into a consumable amount of data for investigators and clinicians. But think about that when you're thinking about putting together your table 1 or reading table 1 in a paper with your patient characteristics. What are we not seeing about these patients? And then on the flip side of things, we really have, in studies where we have a lot of acute data, we often have very minimal follow-up windows for patients with severe brain injury. 2 weeks, hospital discharge, 3 months, maybe out to 12 months is the max that we'll get. But we know now from several studies, some of which are emanating from the TBI model systems, that patients with the most severe brain injuries can sometimes take a decade or more to recover. So this is some data from Flora Hammond using TBI model systems. And what she found was that when you take a look at patients who are admitted to inpatient rehab without command following, so that's that same cohort that we looked at a few slides back, many of those patients by 1 year recover on the FIM, which is the functional independence measure. This is just the self-care score, a kind of a composite score for self-care. Many patients achieve the maximum score and they stay there all throughout a 10-year follow-up period. Many patients, on the other hand, are at the bottom, at the floor of that measure. They don't recover any kind of independence and they stay there throughout the 10 years. But look at these two groups that make up more than 30% of the sample. In these two groups, we have a pattern of recovery that goes on and accelerates over 10 years. We have very few studies, in fact, maybe this might be the only one, that comprehensively studies outcomes that far post-injury, which is really important to do in our severe patient population. Next, let's talk about missing follow-up data and missed milestones. So track TBI was really focused on trying to follow as many patients as possible, because once you lose patients to follow up, your sample size goes down, your generalizability goes down, the conclusions you can make from your study go down. Nevertheless, even though there was this very focused and concerted effort to follow patients, you can see in this consort diagram, we started with 2,200 patients who survived the initial period, acute injury. By 2 weeks, we had lost 20%, so we had only managed to follow about 80% of the patients. By 12 months, we had lost nearly 30% of the patients. So think about those 30% and who they represent. And this really affects our ability to make conclusions about the outcomes. So this is a little bit of a busy table, but it basically shows you on the left-hand side all the outcome measures that we looked at in track TBI, the global outcome measures like the GOSI, neuropsychological assessment here in this red box, and we'll talk about the CRSR in a minute. And within the patients who were followed, how often those measures were actually completed. So the GOSI was the primary outcome measure. So when we were able to follow a patient, we followed them on the GOSI 100% of the time. But when we needed patients to come in person, or participants to come in person for a neuropsychological assessment, you can just eyeball these numbers. Our numbers dropped dramatically. And in our severe patients down here, the numbers dropped dramatically as well. So just to kind of present that data in a slightly different way, this is a representation of the percentage of participants who completed a given measure of the participants who were followed. So we're only talking about the patients who were able to reach for a follow-up on the GOSI and on some neuropsych assessments. And in blue is our percentage of completion for those patients who were well enough to be able to complete neuropsychological assessment. So they were able to sit down for a 2-hour battery and do not just a global function measure, but also the trail making test and the RAVALT and the WAIS. In orange, this is the bar for patients who are not able to complete neuropsych assessments because they are too cognitively impaired. So they don't have any of this cognitive information, the blue bar is in the middle, but a caregiver on their behalf was able to complete the GOSI. And so we have very high completion rate here. What we wanted to do in track TBI was not limit ourselves to getting good comprehensive information on the lowest level of patients. So we designed a flexible outcome battery that will be able to accommodate patients with prolonged disability due to traumatic brain injury by including not just a global function measure, which you can do by telephone, but an in-person measure, again, that we're bringing in the CRSR, the Coma Recovery Scale Revised, so that we could follow people as they recovered consciousnness over time, because the GOSI really can't capture that level of granularity. The problem is that we only got about 35% of patients who were followed to complete the CRSR. These are patients who were not able to come back in person. They either had too many medical comorbidities, so they couldn't travel safely. They lived too far away. It was too complicated to pay and too expensive to pay for ambulance transport for a research study. So going back to this issue of follow-up, we're a lot less likely to follow in person the patients who were most interested in studying, those with the most severe brain injuries. So what can we do about this? How does our field move forward from this to be able to follow more patients? So we really learned an important lesson in track TBI, which was that we need to have more assessments validated for remote administration and more assessments that are validated to be administered to the caregiver and the surrogate. And there are a couple other lessons learned here. We don't have to go into each one of them individually, but these first 2 points we wanted to address. So we designed a phone-based coma recovery scale revised so that we could assess patients longitudinally on a comprehensive behavioral measure without having them come in person. And we did that by designing an interview for the caregivers, where we took the items from the CRSR that differentiate patients who are in the vegetative state from those who are minimally conscious, and we asked caregivers to report back to us whether the behavior is consistent with those diagnostic categories. Occurred never, some of the time, most of the time, or always. We then brought the patients back to our facility in person. We did an in-person CRSR, and we looked at the concordance between the patients and the caregivers. And we were pretty nervous because caregiver report, especially for something like, withdrawal to noxious stim or visual pursuit, isn't necessarily going to align with our in-person assessment. And we were very happy to find that in our accuracy on the phone-based CRSR compared to the in-person CRSR was greater than 0.7, which was our threshold for saying that the measure was valid. So this phone-based CRSR is in the works. It hasn't been published yet, but will hopefully be able to be a tool that we can use to follow patients with severe traumatic brain injury much better longitudinally. All right, lessons 7 and 8, I've kind of lumped together here, and that is there are many confounding factors that we do not measure when we do our TBI studies. When we do our studies, we're able to measure things like age, education, sex, race. We can look at insurance and how that affects TBI recovery. We can look at TBI severity here in quotes, because we know that that needs to be much more precisely measured, not just with behavior, but imaging and blood biomarkers. We can look at things like time post-injury. But patients with TBI come to the table with many more factors that could affect their recovery. And many of these factors have been studied in isolation. Things like access to care, social networks, even traits like resilience, genetics, the wide range of acute and post-acute interventions that they could have had, prior history or current history or of substance use, pre-injury factors like medical comorbidities and so forth. We don't measure these things, the ones that are kind of in that dotted box, or we don't measure them to the extent that we should, or if we measure them, we very often don't include them in our larger prognostic models. So in TRACK TBI, when we look at what affects our trajectory of outcome, who is likely to have that GOSI 4 and above or favorable outcome versus an unfavorable outcome, we don't really factor in whether or not that person has family and close ones who can bring them to appointments, who can support them through their recovery process. And we don't really necessarily look at how much access they have to care or how they leverage it. We have measures of resilience after the TBI, but we don't have any measures of resilience before the TBI or any measures really of prior history. We have medical comorbidities, but not really at a granular level. And all of these things can affect TBI recovery. Not only that, but most of our studies in TBI, with the exception of our interventional randomized control trials, are observational or they're retrospective. And we either don't collect this or we can't go back to collect this information. We're starting at a time point and we're going forward. So what can we do about something like this? And this is a pie in the sky idea, but if anyone here has heard about the Framingham Heart Study or studies like it, where before somebody has a heart condition, before somebody has a TBI, this actually happens in football, people can get baselined, by their healthcare system, by their primary care physician on a number of different metrics. And that can be entered into either a medical record or a global research database so that we have information about people before their TBI, and we can understand how pre-injury factors influence post-injury factors in TBI recovery. So this is kind of a larger scale idea of thinking about how can we get early information before the injury to help us understand post-TBI recovery, and something that most studies are really not able to and not addressing at this time. All right, in the last few minutes, I want to really focus in on outcome measures. So we've talked a lot about the GOSI, and the reason that I've talked a lot about the GOSI is because that is the only outcome measure for TBI that's supported by the U.S. Food and Drug Administration, the FDA. It is overwhelmingly, if you look at the literature, the most commonly used outcome measure for TBI. It's really across the board, almost always included in TBI outcome studies. So if you're not familiar with the GOSI, it has 8 categories that are represented here. Those are those same categories we saw in the TRACK TBI studies that look at disability split out into lower and upper disability, a severe disability, moderate disability, and good recovery. And there's a couple important things to point out here. So first, this item, this lower severe disability, I'm going to show you in a moment the very wide range of function that's associated with lower severe disability. And on the other hand, on the upper end where you have good recovery, You have what's called good recovery on the GOSI, but you can still have, as many papers have shown, significant cognitive impairment and poor quality of life. So this is a very coarse measure, and one that has never really been vetted by patients and families to see whether or not this is really important to them when it comes to TBI outcome. So this is a figure that maybe some of you have seen me present on before that maps the GOSI categories that I just told you about. So 3 is that lower severe disability category, 2 is a vegetative state, 8 is a full recovery, against the functional independence measure, or the FIM. And each dot here represents a participant within the TBI model systems. These are patients who were admitted with a disorder of consciousness. So the GOSI category of 3, which is where we find the overwhelming majority of patients with severe brain injury, actually spans the full range of the functional independence measure. In other words, in a GOSI category of 3, if you're down here, you would be completely dependent on the FIM. And if you're up here, you would be completely independent on the FIM. What this tells us about the GOSI is that the category of 3, which is almost always associated with quote unquote unfavorable outcome, both in clinical practice and in research, is completely nonspecific for level of independence, despite the fact that it's supposed to represent somebody who is essentially completely dependent. Another measure that we use to assess independence or function in patients with disorders of consciousness or severe traumatic brain injury is the disability rating scale. This actually spans from no disability all the way up to very severe disability in a vegetative state. And the dots here are colored to represent the different categories on the DRS. So the DRS is a little bit better. You can actually visualize that the more severe colored dots are down here at the bottom half of this scale, and the less severe are up top. But still, even with the DRS, we have a very wide range of distribution of scores within the GOSI score of 3. So why is that a problem? Going back to our data from Track TBI, so this is the same data that you saw, 6-month recovery in patients with severe traumatic brain injury based on the GCS, and more than half the patients have a GOSI score of 5 or above, and I'm using 5 here because I want to really take a look at the 3s and the 4s. The 3s and the 4s are considered to have a severe disability, but what does that really mean on the GOSI? For a GOSI score of 3, you can be anywhere from in a minimally conscious state to being recovered to a point where you can be home alone for up to 8 hours. And for a GOSI score of 4, you can be anywhere from being left home alone for 8 or more hours to being home alone for up to 24 hours. So taking together, this severe disability category represents patients who are maybe just able to track or follow some commands, all the way up to patients who are able to be left home alone for up to 24 hours. It's a very wide range, despite the fact that it's considered a poor outcome and it's considered a severe disability. I would argue that perhaps a GOSI score of 3 or 4 for many people wouldn't be considered an unfavorable outcome. And in fact, when we look at the GOSI mapped onto satisfaction with life, these are, again, very preliminary data that were pulled together by Dr. Katie Golden, who is an OT, rehab sciences PhD OT student in our group. She took each one of these GOSI categories in the TBI model systems, and she looked at satisfaction with life scores within each GOSI category. And this red line here represents what's been in the literature published as the poor life satisfaction category. You can see here visually that between a GOSI 3, a 4, a 5, even a 6, you have satisfaction with life scores that span the range of poor satisfaction with life all the way up to what would be considered normal satisfaction with life. In fact, these upper 3 categories, there's no statistical difference in the median score of satisfaction with life. And you can see a trend towards satisfaction of life scores being higher as you get to GOSI 6, 7, and 8. But it's nowhere where we would think it would be if we think of GOSI 3 as being unfavorable outcome. We would think of this as being people who are not very happy with their life. Nevertheless, you see a spread that's pretty evenly split for GOSIs 3, 4, and 5. So what are we doing about this? One thing is that we're looking at different rating scales that we can adopt or amend to get better at the question of dependence and independence. Dependence is a very important outcome. We're just not measuring it very precisely in most of our studies. So we came up with a new composite measure. It's called the DRS Depend. It takes a couple of different items for the DRS to really home in on somebody's ability to perform basic activities of daily living. And we found that the DRS depend is more specific for independence based on the FIM as compared to GOSI scores or total DRS scores. But even with this, I want to go back to the question of what should we be considering a favorable outcome after TBI? After all, nearly all TBI studies dichotomize outcome as favorable and unfavorable. And if you look in the literature, we don't have agreement in the field on what it means to have a favorable or an unfavorable outcome. Every investigator, every study defines that a little bit differently. And it's also important to note that we've never asked patients or caregivers what they would consider to be a good outcome after TBI. And so we're doing a little bit of work in this domain now, trying to pull together key stakeholders so that they can tell us what is important to you in your recovery. And we can start studying those recovery milestones and not the ones that we have been studying for the past 40 years or so. All right, just to wrap things up, there is wide heterogeneity in how studies approach TBI research. And that is a very big problem because it's really hard to compare across studies, and it's really hard to get meta-analyses and longitudinal studies put into the context of the broader scope of the literature. So I just want to make you aware of an effort by the Curing Coma campaign that is now really wrapping up to establish common data elements. These are recommended data elements that should be collected if you are studying disorders of consciousness, so that we can assure that at least we have some standardized base for learning about recovery from severe TBI and non-TBI going forward. And you can go on Zenodo, or you can use that little QR code, but this is all now published and available in PubMed through the Neurocritical Care Journal. All right, so to wrap up, we have important limitations to consider with TBI studies, but many of them can be addressed with innovative study design and thinking through these limitations ahead of time. We certainly need more large multi-center studies with consecutive enrollments and long-term follow-up. And I really think this question of what should we be looking at for outcome needs to be addressed before we spend too many resources studying outcomes that might not even be relevant for our patients and families. And I will stop there. I'm going to stop the sharing here and hand it over back to Dr. Weintraub for the Q&A.
There's some feedback. Okay, I can't not thank you enough. I'll do the best I can to articulate a couple of the questions in the chat box. Relative to engagement of higher numbers in your data sets for analysis, the question is, how do non-typical research centers who have a large volume of patients perhaps contribute in some of these efforts?
Good question. So studies like Compose aren't necessarily targeting only academic centers. In this first phase of the study, I think those are the centers that have responded to us, but actually it's oftentimes the smaller community healthcare systems that are the most eager to participate and contribute data and might even have some resources to do that. I think that we need to start it's hard, right? It's hard to go outside of your academic research center and into the community to do this. You have to break down silos, you have to break through healthcare system walls, but I think we need to start writing this into our grants. We're not just going to study this for people who come to MGH or to Spalding. We're going to go outside into the community, and we're going to ask for resources from the federal funding agencies to do that. And then once you've established, look, I have a mandate from the government, they're giving me money, I need to study this, then you go to your administration and you reach out to the administration of these other smaller sites to try to have some dialogue about where data can be acquired and shared anonymously to try to expand it. I think that's an ideal model for the future. I don't know. I'm trying to think. I think there are some successful examples of that in the past. But the other thing I'll say is that we have to have champions in those community centers as well. So it's really up to us when we have these research studies published to go into those community centers and do the education so that people know that this is a problem, people know that we're studying it, and that we are invested and interested in that patient population. I mean, most of our DOC patients, that's where they are,
There's 3 more questions in the allotted time. In that preliminary data set on satisfaction with life, how did that compare with normal population?
So we haven't looked in the normal population, because this particular analysis is very specific to the GOSI. And so in the normal population, if you look, you assume that people don't have a GOSI score that's less than 8. I think overall, if I were to have to guess, overall, probably the satisfaction with life might be a little bit skewed towards less satisfaction. But I think what's important is not to look at the median score, it's to look at that spread and to recognize that many, many, many people report a very good and optimistic satisfaction with life despite having significant disability. And that's the thing that's important to remember, that to me is that disability doesn't mean a less meaningful or satisfaction with life for many people, although it could certainly for some.
Excellent. 2 more quick questions in the allotted time. One is, do you think, and maybe you perhaps could go out on a limb, of getting close to a professional consensus, at least, on the definition of good outcome?
I don't think we're quite there yet. I think that we will probably have a range of different outcomes that people should study, not in the context of good versus bad, but in the context of what do I want? What level of function does this study want to learn about? I think that we should move away from using terms like favorable and unfavorable, good, bad, optimistic, less optimistic, and say the likelihood of achieving independence in the home is X, with a certain amount of uncertainty around it. The likelihood of achieving return to work is this. The likelihood of achieving participation is this. And then instead of dichotomizing this very global outcome into really 2 pieces, you're breaking it down and you're kind of dichotomizing each one separately. And you're saying for each one, you have this chance of reaching that milestone or that chance of reaching the milestone. And it's not that hard statistically. I've talked to my statistician friends, and we always talk about dichotomization because it's easier to digest and it's easier to work with statistically. But I just don't think that's necessarily the case, and it's not the way that we should be moving forward, in my opinion.
Okay.
Yeah.
And then the very last question, I think this is apropos to finish on, would be the pros and cons, if you will, of machine learning paradigms, AI. Because I know many of us are seeing studies attempting to replicate, previous data now analytics using machine learning, and certainly there are some opportunities, but I think there's some bewares that I wanted to get your take on at this point in time.
Yes. So I'll comment on 2 things. First, the output is only as good as the input. And with AI, you basically take an unbelievable amount of input, typically not curated and not vetted, and we don't look for missing data and all those things, and you put it into this machine learning algorithm and it gives you the output. But many times the data going in aren't very good. And so the confidence that you have in the data coming out should also be not very high. And the other piece of this is that you can do machine learning on basically any data set you want to, but if you don't have the clinical and the investigational expertise to identify, first of all, the limitations of the process, but also to interpret the data on the other end, you can get into really big trouble, because you can have an output from that AI that doesn't make any sense clinically, or that could even be harmful. And if you publish that completely agnostic to the clinical environment in which it's going to be used, you can actually cause a lot of harm. Now, that being said, I think if used correctly and very carefully and methodically, I think there are many, many potentials, especially as we acquire more and more data in the acute setting with continuous monitoring and so forth. But I think, as we've seen with ChatGPT and other AI systems, a lot of caution is needed as well.
Well, thank you very much. This was an enlightening talk. And for those that want to hear you speak live and in person, I will say Dr. Bodine will be at ABI 2024. Thank you again, everyone, for participating in this webinar.
Thanks, everyone.